Okay, 1 minute. Okay. Okay, Dr. Frank, are you ready?
Yes.
Okay. Good morning and good evening for all the members in Chang-Gung Forum webinars. How are you? I'm Dr. Peng Yun. Today's our topic is to discuss things about fat injections. We are so happy and so honored to invite one of our member of a craniofacial team, Dr. Frank Chen, to give a topic micro-autologous fat transfer and the nano-fat transfer. So please enjoy his talk. Okay, please, Dr. Frank.
Good afternoon or good night, everyone in the web. My name is Frank Chang. I am currently the attending staff in the Chang-Gung craniofacial team. I am honored to be the part of the craniofacial team. And currently, I am specialized in cleft surgery, orthodontic surgery, and fat transfer. Today, I will share my experience of micro-autologous fat transfer and the nano-fat transfer. Currently, nano-fat, I think, is a new terminology for most of you, but this nano-fat has been published more than 10 years, and it is a hot topic on 2 years before the COVID-19, the IFAT meeting. It has a very big panel of that, and today I will present what is nanofat and what is its application. The modern fat transfer was popularized by Dr. Sidney Coleman, and in his book, he told us that I have witnessed scores of plastic surgeries and have unusually privilege of knowing the patients before the surgery and then following their adjustment afterward. And I think I have witnessed also many changes of my patients after the plastic surgery, like they get married, they go out frequently. And lastly, I witnessed one lady that has facial orthodontic surgery, fat injection, later on breast augmentation. Then I saw her get tattooed. So I asked her what happened. She go out frequently to the beach and show out herself. And right now she's a happy person. So in plastic surgery, we have many privilege to knowing the patient before the surgery and following the adjustment. What is the current trend? If you look the injectable in American, US, there are 2 billion of people has injectable. And the total facial rejuvenation surgery is only like 100 times less. And others are even less. That means non-surgical procedure like Botox and hyaluronic acid is the #1 or #2 cosmetic procedure in USA. And I think in most countries is the same. And if you look how close, the American people spend like $1 billion and $225,000 on their face. And if they really satisfied with botulinum toxin, especially the hyaluronic acid injection, they will look out for the future permanent injection. So want to look with minimal time. That's a minimal procedure. And of course, they search for longer lasting procedure. What is that? fat injection. It has described as early as 1893 by Nuber. Afterward, 1983 and 86, the injection of fat graft to the face has been published on the early age. And the advantage is being permanent into the recipient side, ability to inject a large volume, and there's no allergic reaction. My preferred donor site is lower abdominal. My personal preference is create a wound in the inside of umbilicus. I do not like inner side because first, I have many very thin patients. If they have liposuction in the inner side, they will affect the contour of inner side. Moreover, the wound is visible if they wear a miniskirt. You can see a wound is visible if they wear a miniskirt. When I go to Japan, my teacher like to create an operation wound on the inguinal area and do the liposuction abdominal area. My personal like is intra-umbilicus incision to do the liposuction. What is the ideal donor site? Padoin published in 2008 PRS that the lower abdominal and the inner side has the highest cell concentrations compared to other area. Moreover, abdominal might have higher soluble factor compared to the inner side and the knee. That's Gracie published in Aesthetic Surgery Journal 2016. Multiple small hole brown tip cannula better than single 3 millimeter hole cannula. And the side hole, if the side hole is less than 1 millimeter, so-called microfat. If a conventional 2 to 3 millimeter hole cannula, we call microfat. On the delivery system, if you can deliver less than 1.2 millimeters of diameter of fat parcel, is called microfat. My personal like cannula is 2 per 3 millimeter, 3 hole on one side. I think centrifugation is still the gold standard. The gold standard of all the processing of the fat. The silicone presented early stage centrifugation, 3000 PRM 3 minutes. After that, you remove the oil part, remove the hemoglobin part, then you put a cotton gauze to further dry out the oil part. This is what's so-called traditional silicone procedure. Do the centrifugation, 3000 PRM for 3 minutes. Then you remove the white red blood cell part. Then the oil part, you will remove it. Then you put a cotton gauze inside, further drying off. This is a conventional way that we process our fat. On Stutz, on 2009, published aesthetic plastic surgery of water-assisted liposuction. The mean for remove the fat is not by mechanical force, it's by water force. Loosening the fat, then do the liposuction, it will preserve more the pedicle. And it has its corrector. Corrector can separate the fat from the water. And Saki published Aesthetic Surgery Journal on 2011 at 1 hour, more than 80% of the fat is survived. But after 6 hours, you can see many apoptosis by water jet liposuction. We have the second generation of human-made water jet liposuction. This is the currently we use the bottle to separate the fat and the liquid. In my personal experience, as similar compared to other mechanical liposuction device, but only disadvantage of this machine is all the tube is disposable, so you might spend more money on the tube than other procedure. Currently, I use more and more power-assisted liposuction because Neck et al. Published in Z Plus 2014 show no difference from the manual aspiration, the cell survival. And if you do the centrifugation, be aware that the lower part has higher density, the bottom more viable cell, more progenitor cell, more vasculogenic mediator. And that's why my teacher, after do the centrifugation, he will try to mix out all the fat before the injection. Don't do the injection directly because the lower part has better survival rate than the higher part. And the effect of centrifugation, but if you have more than 4,000 PRN 3 minutes, that if speed under the 4,000, do not change the percentage of survivability. But if you have more than 4,000, the cell viability has become less. And Yoshimura presented his, my teacher presented his work on published on PRS 2008, show that 1,200 G for 3 minutes has best survival for the edible stem cell. And if you have more than 3,000 G, you will damage ADSC. 1,200 G is around 2,300 PRM. So currently is 1,200 G for 3 minutes or 2,300 PRM for 3 minutes. But still, many people still use 3,000 PRM. This is the original presentation by Sidney Coleman. And Dr. Gigotti is a very famous fat injection plastic surgeon, and he published this in 2008. What about placement? I mentioned that 1.2 millimeter below that is so-called microfat injection. If bigger than 1.2, we call macrofat injection. And we supposedly a maximum amount of contact of fat with vascular tissue in graft site. That the viable tissue are observed on the peripheral zone, that is 1.5 to 0.5 millimeter. So if we have much more survival area, we have less necrotic area. So currently is advised 1/50 or even better, 1/60 or 1/70 millimeter per withdraw, that called microfat injection. You can use sharp tip, or blunt tip. Dr. Sidney Coleman presented early on his work that the blunt tip, 18 gauge or even bigger, should avoid or minimize the intravascular injection or thrombosis. So in the phase device, you use blunt tip, 18 gauge or 16 gauge is fine. And don't use sharp teeth, especially small needle on your face, because once you push backward, especially periorbital and nasal area, uh, even the incidence is very low, but blindness has been reported or cerebral accident. I have no conflict of interest. Currently, we have two types of gun, and my personal preference is MAF gun, micro-autologous fat injection gun, because it has divided 60, 1 over 60, 1 over 90, or even 1 over 240 per injection. And especially the parcel is much smaller. This is the biggest injection parcel is 1 over 60. You can see it's much smaller compared to our conventional injection gun. And moreover, if you have that small parcel, the survival rate should be better. I think there's two methods for obtain the SBF or fat-derived stem cell. In Japan, I learned from my teacher how to process the SBF from the fat. But if you close look, the collagenase is mainly for research use only. That means let's still in Taiwan, we don't have medical use or medicine that has the collagenase. So in Taiwan, we are not able to use this lab collagenase to do the digestion and do the incubation, centrifugation, and get the SBF, which contain the fat-derived stem cell. And moreover, we have another way, so-called mechanical degradation. This is Tona et al. Presented on PRS 2013. This is his video. And he presented how to do the so-called nanofat. It's not really nano particle. It's the name he given to the fat he do it. So he calls it nanofat. Many just pass this fat 30 times through each syringe. You can see just push, 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 and more push. And you just ask assistant count 30 times. Then you put to the fine nylon gauze or infiltration gauze, and you can infiltrate your fat here. You can see further squeeze the fat, and this liquid here is filled into 1 cc of syringe, and with 27 gauge of needle for the injection, very superficial injection like a subdermis injection. You can see this is 1 cc, and after you pass to the 5 cc, it's ready for the injection. And currently, nanofat has been published, used for the scar, for the 5 wrinkle face, two papers published talking about the dark circle around the lower eyelid. And I will present those applications in the further my presentation. And in his study, this is Microfat. Microfat. Microfat is when you harvest with cannula bigger than 1 millimeter of hole. This is 1 millimeter hole, and this is so-called nanofat. Processing of fat after you do the liposuction. And if you can take a look, the adipose structure has been totally distracted with nanofat compared to the macro and the microfat. If you the adipose derived stem cell culture, show no difference between three groups. This is nanofat, microfat, and the macrofat. And if you culture in the fat cell medium, that show fat vacuous formation. That means this stem cell can differentiate into fat cell. And this is macrofat, microfat, and the nanofat. That means if you process the microfat, the stem cell will still be viable. And this is my old method. You just pass through 30 times, and you filter with these fine nylon gauze, squeeze and squeeze it. Then you fill 1 cc syringe. And my newer method, I will explain you from liposuction. Currently, I use a machine to inject Chun-Shin solution. My Chun-Shin solution is 500 cc normal saline, and with only 20 millimeter, 1% zero kain. And use a machine, you can very quickly inject the Chun-Shin solution around the entire abdominal wall. You can see I just inject around the abdominal wall using this machine, and the 500 cc of Chun-Shin is injected entire lower abdominal. As I aforementioned, that lower abdominal contain most higher cell concentration. Then I use this so-called mechanical assisted liposuction because it's much quicker. The cannula is 4 millimeter of diameter, and the hole is 2 per 3 millimeter, 3 holes. And you can see very quickly I do the liposuction, and the fat is coming out to this collection bottle. This collection bottle is 150 millimeter. You can see very quickly because this is water jet liposuction. No, this is power assisted liposuction. This tip will vibrate very quickly itself. So my liposuction should not be so forceful. You can see this lady has only 45 kilo of weight. And this abdominal not so many fat, but you can see I just go around and the fat collected very easily and very quickly. And this is not only save my time, but also save time to harvest the fat. After that, I put to the, this is a 5 nylon mesh covered with cotton gauze. And this is the fat that I just harvest. And you can see this almost no any black clots, because if you make the right layer, I so-called middle layer, because if you go superficial, that's a lot bad. So if you go to the middle layer, you will probably mostly harvest the fat like this. It's no red blood cells. And the only blood spot, if you can take closely, maybe here I can see a tiny blood spots, maybe, but that's a pure fat. If you can do the liposuction like this way, you can further reduce the ecchymosis of abdominal wall, because sometimes the patient complain about the ecchymosis. And if you take a close look, this is pure fat. And no blood cell, and very pure fat. And you can see this nylon gauze, there's no blood stain on it. And you can pretty make sure that your abdominal ecchymosis is minimal. The patient can walk, can go the same day without any problem, and the abdominal wound is very tiny. I always like to hide it inside umbilical. This is the tulip, the commercial available nanofat producing. This is 2.5 millimeter hole. Then I use 1.5 millimeter hole. If you feel the fiber stuck on that, you just remove the fiber and keep going. So this is compared to the conventional microfat graft. And if you inject, you can see this is a parcel, the parcel of the fat going through. And you can see that this is very tiny, small fat parcel. And if you compare to the nanograft that I was showing on, this is nanograft. And because the fat has been liquefied, it's just liquefied. There's no viable adipocyte. Only stem cell remain and the cell debris, a lot of crushed tissue. And the study show if you inject this, it will increase the stem cell amount because they call it stress-induced stem cell. Moreover, you will have more collagen formation and the skin will have rejuvenation effect. For the frontal area, I like to inject from the temporal area and go through second, 3, 4. This is so-called macro or microfat injection. The parcel of fat injection to fill the space. Why the temporal area first? Because less vessel. If you start with here, many times I inject the vessel and the bruising and it will affect my appreciation of the amount of fat. So I really like to start here because less vessel encounter. I always inject superficial. On my initial practice is deep injection, deep to the temporalis. It's more smooth. However, if you inject inside muscle, because every time you chewing, you speak, you mobilize the muscle. And the fat is between the muscle. And if less immobilization, less survival. So currently, I would like to superficial injection, less more vessel, however, has better survival. Less painful because every patient complains soreness with chewing. But however, superficial has more irregularity. Like a hyaluronic acid, if we really want to inject smooth, you just very deep injection inside the fascia. I can guarantee you have very smooth contour without irregularity. To the superficial, you need blunt tip. However, deep injection, you need sharp tip because the fascia is a very dense barrier. The blunt tip will not penetrate it. And if the patient has scar defect like trauma patients, you would like superficial because deep injection, you worry about the scar defect. For the nano fat, I will inject very superficial to the wrinkle area, especially deeper the statistical the wrinkle, more nano fat needed. This video shows the nano fat injection. You can see this wrinkle is previously injected with microfat. After that, you can see I just feel the wrinkle. You can see the yellow color of the nanofat field. This is 30 gauge of the needle. And you can see the fat even come from the patient's sebaceous gland duct opening or the sweat gland opening. And you can see even the needle is not passed out, but the fat come out with the normal skin, because this is really superficial. It's like a subdermis injection. And the upper orbit is just micro fat injection or a macro. I would prefer micro because less looping. Dr. Lim presented his work, multiple superficial injection, but I did not work out with this method because upper lip, if I use this method, looks so puffy. My personal injection is below the orbital, just inside, very deep. You can see this is before and just after. You can see very smooth contour because it's very deep. And this is 6 months after resorption. You can see is much upper orbital hurry improved. For the nose, I presented 2015 on annual plastic surgery, the one of the first cosmetic use of fat injection rhinoplasty. The survival rate, mean survival rate is 45%. You can also inject the chin for the chin augmentation, but this is mainly the microfat injection, not nanofat injection. For the T-stroke, I would like microfat injection deep enough, because if you go superficial, here is a very sensitive area. If any looping created, the patient will complain for their life. So this is microfat injection from different direction, very deep, middle, and deep, as deep as just above the periosteum, so-called supraperiosteum injection. And if I use nano fat, I will go very superficial, just behind the dermis. And this video shows one of my patients with the typical presentation of dark circle. You can see this is dark circle with the teeth roof. The first, the deepest part of the teeth roof is marked with the marker pen. I always like a 3 points of injection point. I just puncture with sharp tip. This is a brown tip, 18 gauge, and the injection rate is 1/60. You can see it's very deep, deep to fill up from the deep inside to correct the T-stroke deformity or nasojugal fold depression. Then this entire area is injected with microfat. Again, this is deep area. You cannot see the tip because it's deep, just above the periosteum. Just above the periosteum, I will fill out the entire area of the so-called microfat to give the support. And this is for the support. You can see very, very deep and almost hit the orbit. Don't worry, because you have a brown tip. You just leave your parcel, and then this is nanofat, very small parcel. And you can see this is so superficial. You can see the needle just below the skin. And then the nanofat will fill out the entire this so-called dark circle area. And if you go to PubMed, there's recently 2 papers talking about nanofat to improve the dark circle. You can see the coloration has slightly improved after surgery. And typically you can observe 1 month, 2 months afterward, this dark circle is getting better and better. You can see this is so-called dark circle. And using microfat plus nanofat, you can see the dark circle just whip off. And the patient has slightly minimal is 6 months after surgery. The patient is happy, and currently I call myself a craniofacial family doctor because the patient frequently bring their sisters, their mother, even their father, their cousin, their entire family to my clinic. I call myself a family doctor. That's once last year my clinic come from number 1 to number 15 patient are entire the same family. And the entire month I have half of my operation is just these two family. And I call myself family craniofacial family doctor because once the patient has this type of result, they will bring all the family. And currently with COVID-19, many doctors are afraid their patient go away, but I have increasing of my patient because my patient told me they can wear the mask, they can hide the injection site. So why not? They come to for the injection. For the crowd fee, if is dynamic, of course, Botox. But if static, not dynamic, you need something to support. That's microfat plus nanofat. This is just after injection, and this is afterward. You can see the fine wrinkle just disappear with the nanofat. For the nasolabial fold, I would like to microfat from the bottom to fill it up. Then the microfat to the superficial, especially the tail, and also the marionette line. So this is a microfat injection from the bottom. Then the upper lip and the lower lip, superficially, I would like a nanofat to fill it up. So I will present only the nanofat because the microfat I have presented many times the microfat. So I just presented the nanofat. You can see it's so superficial. Every time you inject it, there's a bulging. Don't worry the bulging because all the adipocyte has been destroyed. So don't worry about the bulging because it will disappear for 100% disappear. And the recent animal studies show the nanofat will improve the survival rate of microfat injection. So you just inject a bulging yellowish, just don't worry, the yellowish will go away in 1 week. You can see so superficial, so bulging, but the patient was satisfied because the coloration, the dark color will disappear, and the tail here so superficial, especially the marionette line. You can do it with the nanofat. Also the upper lip, also the microfat fill out the skeleton. Then this small wrinkle, this uh, small line, you can fill with the my nanofat, and this is 2 months after surgery. You can see a beautiful lip, rejuvenated lip, and you can see a very smooth upper lip after the surgery. So this is the one of my patients. You can see upper eyelid microfat, lower eyelid in transconjunctiva, incision remove the fat injection here, fat injection nose, upper lid nanofat, and you can see the nanofat injection is so superficial, cause a bruising and the bulging here. Don't worry, it will go away. And you can see yellowish with the nanofat, and you can see entire periorbital area with the nanofat. This is a 3/4 view. After surgery, just don't worry about the bulging with the nanofat. And 1 month afterward. she has 10 years less. And after resorption, before and after, this is 6 months after. So you can see the fine wrinkle just disappear. Don't worry about the bulging created with the nanofat because you will totally disappear. And with the nanofat, you can see the dark circle being improved. And from the bottom up, the microfat will create the very beautiful medial cheek augmentation. Dr. Rorick published on PRS that medial cheek augmentation will have rejuvenation effect, especially on women. You can see this before after. Three-quarter view. And this is her, the same woman, before and after. Three-quarter view and the lateral view. And the result was so good. So our we have Chang-Gung hospital, but we also have Chang-Gung clinic. I asked the patient, she agreed. So we print out this and put on the internet for the patient see what is the fat grafting before and after. And she also bring me her sisters, her two sisters for facial rejuvenation, her mother, then her cousins, and the entire family been to my clinic because she's so satisfied and she agreed. I use her photo without put any mosaic, even on the internet. The last topic is the scar rejuvenation with microfat. This is 30 gauge. And the previous injection, I already inject the microfat. I don't want to repeat microfat because I presented many times that. And this is the so-called nanofat. And you can see the injection is so superficial. You can see even the needle right here. This is my needle right here, so superficial, and the typical presentation is yellowish after the injection. This is so superficial, so superficial. You can see that, so superficial. And all you are doing is just intra scar injection, just like you inject steroid. And you can see there's a bulging outside here. Just don't worry, because no fat will survive. Any bulging will disappear in 1 or 2 weeks. Mostly after 3 days, 4 days will disappear. You just explain, don't worry about the bulging. You can see the yellowish here. So I just keep on. This is so minimal invasive. You can do the IVG anesthesia or even under local anesthesia, and the entire scar is injected with so-called nanofat injection. You can see very superficial injection, and this is goes through the entire scar. And don't worry, the bulging will disappear. You can see another bulging here. Don't worry the irregularity, because it's only stem cell. There's no live adipocyte. So this is after 1 section of injection. You can see the scar improvement. This is 6 months after surgery. Thank you a lot. Any questions? I will great to answer you about the nanofat, microfat, or macrofat. And in combination, you can make a beautiful patient and become a family doctor. Thank you.
Okay, thank you, Professor Frank Chen. We welcome all the questions, and you can post your questions in our chat room to show. So one question here I want to ask Frank is that in your last one, you inject the nanofat to the scar. So one is our audience to want to ask what is the amount that can be injected in this area?
if you go through the literature, it has been published already, the Nanofat and the improvement of scar. And in my personal experience is you can inject as much as possible. In this version, I inject more than 2 millimeter of so-called Nanofat. If you want to inject 10 millimeter, it's fine, okay. But my personal experience is just over the scar. Just feel the entire scar with yellowish. I think it's enough. But if you want to inject more, if you have more, why not? Because every time you inject it, all the uh, all the liquid will get resorted. Only stem cell will survival. So the scar will improve. Just 1 or 2 cc should be okay.
Okay, thank you. The second question is that uh, what kind of the needle do you use for the intradermal injections of nanofat? Normal sharp cannula or spatial blunt cannula?
Okay, as I mentioned in the periorbital, this graphite light is okay because you inject so superficial. Uh, if you really study well, here the vessel is not like so superficial. But if you go to the lower orbital, if you see the original presentation of nanofat is with 27 gauge sharp tip. In this area, I think is really dangerous because the vessel here is around 0.8 millimeter of diameter. 27 gauge of needle, you probably will penetrate the vessel and the intravascular injection. So on the nasal dorsum and the infraorbital area, just like the video I presented, I would like this video, I would like to 18 gauge brown tip for the lower because there has been published brightness associated with the hyaluronic acid injection or fat injection or associated with sharp cannula. But if you use brown tip 18 gauge cannula, the diameter is around 1.1 millimeter of diameter. You cannot penetrate a brown tip of 1.1 millimeter of cannula into a zero point 0.8 millimeter of vessel. 0.8 millimeter is outer caliber. The inner caliber is much smaller. So I feel safe of the periorbital area and the nose area with brown tip. Other area like this, the small wrinkle, if you go very superficial, subdermis, my personally because this is 30. But if you don't have 30 gauge, 27 or 25 gauge is fine.
Okay, so the next question is what is the durations of interval if procedure need to be repeated?
A long time ago, I hesitate to repeat the procedure as early as possible. I noticed that the donor site morbidity is high. That means the patient is still healing from the previous liposuction process. There's a lot of fibrosis, a lot of new vessel formation. So if you do it early, 1 month, 2 months, the second time, if you do the same procedure, you will encounter a lot of ecchymosis, a lot of bruising, and your cannula is difficult to pass through the previous liposuction area. Currently, I would like to wait 6 months at least. Moreover, if you look how the survival rate of the micro or macro fat, it has been demonstrated that the fat is stable mostly around 1 year, but most report is around 6 months because 2 to 1 years of follow is difficult for most of surgeons. So I think 6 months is the minimal time to do the next surgery. Right now, I don't do it within 6 months. I will advise after 6 months because the fat survival rate, the survival mostly after 6 months is stable. You need a stable amount to do the next. Otherwise, your resorption rate is high.
Okay, so the next question is do you always use the methadone for nanofat injection?
No, because the mouth gun is only blunt tip. If you need sharp tip, nanofat, you just need the conventional gun or just use spiral 1cc needle, use a hand push. And but if you want a better fat survival, the macro or micro fat, I would strongly advise Mafgang because just like this slide I presented the parcel. The Mafgang is the only media that allow you to consistently do the 1/60 per withdrawal. And the Sidney Coleman published this on 2006 that the better survival rate is 1/50. And the Yoshimura, my teacher, on his last publication is 1/70 millimeter per withdrawal. So only Mafgang can do that. I don't have such a fine hand like a Sidney Coleman. He claimed that every withdrawal he is able to do it smaller than 1/50. I cannot do that. So I need a consistent instrument, especially the periorbital area. And in nowadays, our center, we have purchased more than 2 MAF guns. The Taoyuan branch has more than 3 guns. So I think like an old time, because I am relative young surgeon. Sometimes I don't get the gun. I can do it with my hand. But if you have gun, I strongly advise use the gun, even it's expensive. But if any looping you create, especially the periorbital area, any looping might be the cause of the lawsuit. So I think Mafgang is safer. So right now, I don't have conflict of interest, but because we have that instrument, I always use it.
Okay, thank you. The next question is, do you overcorrect with the microfat graft or with the nanofat graft?
Nanograft, I always overcorrect because the margin, don't worry the margin. I always mention that, don't worry about the margin. What about the micrograft? I do a survey myself. The survival rate range from 25% to 75%. That means 20% of overcorrection is safe with my personal experience. So currently I do 20% of overcorrection. So you can see after the surgery, this is just right after the surgery. And if you take a close, this is the most prominent area. There's 20% overcorrection. This margin over the most prominent area. And here is also a 20% over margin. And that the most prominent area became less prominent. And the least margin, don't worry, because if nanofat causes the least margin, don't worry, it will not persist after the 1 week or 2 weeks.
Okay. Okay. One more question, Dr. Frank. Do you believe the storage or store fat graph for the next time's injection? Maybe the fat bank? Yeah.
That's so-called frozen fat.
Yes.
Uh,
So what's your opinions about that?
that's all questions. Like the first, can you guarantee your storage is sterile? That means you store in the refrigerator, right? And after that, you just warm it up. And can you keep the fat stereo whole process? The first question. Second questions, if you want to drink a milk, you want a fresh or a frozen 1 year's milk. I think Korean doctor do a study that the frozen fat has less survival rate, but less don't matter, it's just less survival. But it has more calcification rate. Once you have one patient calcified and duration here, they will complain for you. So the video I presented is uh, the same thing as my daily practice. And I think this video is only like 4 or 5 minutes. In my daily practice, I only spend 10 minutes to 20 minutes to harvest the fat. Why not? And moreover, another question is, all the frozen fat legal? If your hospital has the level 1 lab can store the cell and the stereo re-inject to the patient, I think is fine. But if you don't have that level of the lab, that means you cannot store it well. I don't think I would advise you do the storage because it's illegal, you know. So the legal issue should be another problem. So you can see this video, I don't know, just 4 minutes, contain most of my procedure. So in daily practice is like the same. In 4 or 5 minutes, I can harvest the fat. What about fresh fat, fresh cell?
Yes. Okay.
And the less infection, less calcification, and the better survival.
Thank you. Okay. Thank you, Professor Frank Chen, about today's very excellent topic to share your personal experience in the fat injection in the face. So I think time is limited, and I think I could conclude this session today. I would like to thank you for Professor Frank Chen again. Thank you for your topic. And I think that we just have the Merry Christmas. And I think 2021 is almost coming. And I wish all our audience in our Chang-Gung Forum have a prosperous new year. We are looking forward to our next webinar about 3 weeks later. And at that time, our presenter will be Professor Renzo Low to address palatoplasty in CLAP patient. He will present and show one personal video to teach us how to do this method. So thank you once again. And we are looking for the new year coming. Thank you very much for today's presentation. Thank you, Frank.
Thank you.
Bye.
Thank you. Bye bye. Thank you, everyone.